Welcome back to the deep dive. Today we're taking on a really fantastic source.
We are.
It's Obstetrics and Gynecology Morning Report, Beyond the Pearls. And we're going to be pulling out those, critical decision points, the real essentials.
Exactly. The goal here is to really synthesize these complex cases, in a way that's high yield and clear. It's for anyone who needs this knowledge fast, but also needs it to be thorough.
So our mission then is to unpack these clinical presentations, look at the differentials, and really nail down the management strategies.
That's the plan.
Okay, let's jump right in. Early pregnancy. Let's start with something that sounds, almost universal, but can be incredibly dangerous. Hyperemesis gravidarum, or HG.
Right.
I mean, pretty much every pregnant patient has some nausea and vomiting, but the key principle here is that you can't always blame it on the pregnancy, right?
That's the absolute #1 pearl. You just can't, especially if the symptoms start late, say after 10 weeks of gestation.
Or if they're just not responding to the usual treatments.
Exactly. If that happens, you have to broaden your search. The differential for severe vomiting in pregnancy is, it's wide.
So what are we looking for?
You're thinking about things like pancreatitis, acute hepatitis, cholecystitis, and even, believe it or not, an H. pylori infection.
Wow. And missing one of those would be a huge mistake.
A major error, all because you assumed it was just morning sickness.
And when HG gets really, really severe, there's a rare but terrifying complication we need to talk about. Wernicke's encephalopathy.
Yes. This is so critical to recognize quickly.
Why is that? What's the mechanism?
It's a manifestation of severe thiamine deficiency. Vitamin B1, the patient can't eat, they're constantly vomiting, and pregnancy itself has high metabolic demands, so those B1 stores just get wiped out.
Okay, so it's rare. What are the numbers?
It's very rare, maybe 0.1 to 0.5% of cases. But, and this is the big but, if you see the classic clinical triad,
Which is the ocular abnormalities, the confusion.
and ataxia, that gait imbalance,
Yeah.
if you see that, you have to act.
And what's the key management point?
You give thiamine immediately, and crucially, you give it before you give any glucose.
Why is that order so important?
Because glucose metabolism uses up thiamine. So if you give glucose first, you could actually precipitate the full-blown crisis by depleting the last of their B1 stores.
That is a fantastic clinical nugget. Okay, let's pivot from that to a different kind of early pregnancy complication. Gestational trophoblastic disease, GTD.
Right, this is a whole spectrum of abnormal placental growth.
And it covers everything from something relatively benign all the way to a true malignancy.
It does. It spans from a hydatidiform mole, which can be complete or partial, to the malignant forms of GTN, like invasive mole or choriocarcinoma.
So the main concern is that a molar pregnancy could progress to GTN. What are the risk factors we should be looking for?
You're looking for red flags that point to a high tumor burden, so things like the uterus being much larger than expected for the dates,
Okay.
or a beta HCG level that is just astronomically high. We're talking over 100,000. The presence of the Nixloca lutein, cysts on the ovaries, is another one.
But I imagine some women progress without any of those signs.
Oh, absolutely. We always caution that many women who progress don't have any of these classic risk factors.
You mentioned that astronomically high HCG. There's a really interesting endocrine connection there, isn't there?
Yes, this is a classic Beyond the Pearls insight.
Yeah.
The beta HCG hormone is structurally very similar to TSH, thyroid-stimulating hormone.
So when the HCG is super high,
It can actually stimulate the thyroid receptor, leading to hyperthyroidism.
so a patient might present with a racing heart, tremors, and you might think it's a primary thyroid problem.
Exactly. But it could be the HCG itself causing it.
That's a perfect segue to another presentation that can mask an underlying issue. Pica. This is not your typical pregnancy craving, is it?
Not at all. Far from it. Pica is this intense, almost compulsive craving for things that aren't food, non-nutritive substances.
Like what? What are we talking about?
We're talking laundry starch, soil, magnesia. The most common one we see, though, is pegophagia,
Which is the craving for ice.
the compulsion to consume large quantities of ice.
Yes. And is there a deficiency that's most strongly connected to that specific craving?
Overwhelmingly so. The evidence is strongest for the link between craving ice and iron deficiency.
So if your pregnant patient is chewing ice all day long, the first thing you should do is check her iron studies.
That's your first order of business.
And how do you manage it? Just tell her to stop.
Well, you treat the root cause, the iron deficiency anemia. So ferrous sulfate, maybe dietary advice to eat more beef or liver.
But the cravings themselves can be pretty strong.
They can be. So you might also advise some behavioral substitutions. For example, if a patient craves the smell of wet dirt, maybe suggest they smell it, but substitute chewing on something like a burned tortilla.
Mm.
It's about managing the deficiency while mitigating the compulsion.
All right, so let's move into our next segment. Let's talk about cervical health, specifically high-grade dysplasia found during pregnancy.
Okay.
So we know that HPV-positive HSIL carries a real risk of progressing to cancer. How does pregnancy change the way we manage that?
It changes everything. The priority shifts completely. While that 6.6% 5-year cancer risk is real in the general population, the risk of it progressing to invasive cancer in just 9 months is incredibly low.
So what do the guidelines say?
The consensus is observation only. You just watch and wait. You defer the full reevaluation until about 6 weeks postpartum.
And what often happens after delivery?
Regression is actually quite common. The dysplasia often resolves on its own.
And let's say it persists, and she needs a LEAP procedure postpartum. Does that affect her contraception options like an IUD?
It doesn't restrict her options, no. She can absolutely get an IUD. But this is where the counseling is key.
What does she need to know?
She needs to know that if she does have a leap down the line, the instrument could inadvertently cut the IUD strings.
Which would make it harder to remove later.
Exactly. It doesn't make the IUD dangerous, but it might complicate future removal, maybe even requiring a hysteroscopy.
That's a great practical point. Let's turn to infection now, HIV and pregnancy. The success in preventing vertical transmission has been incredible.
It's staggering, really. The mandate is crystal clear. Start antiretroviral therapy, RT, as early as you possibly can.
And the standard regimen is usually a combination of drugs.
It is. Typically a dual NRTI combination, plus either an integrase inhibitor or a ritonavir-boosted protease inhibitor.
What's the key metric we're aiming for? The number that tells us we're winning.
The goal is an undetectable maternal viral load near delivery.
And what does undetectable mean in this context?
We define that as less than 50 copies per ml. When you achieve that, the mother-to-child transmission rate just plummets.
How low does it go?
To an astonishing 0.09%. It's incredible.
And this is why we have to test everyone in labor if their status is unknown.
Absolutely. Rapid HIV test. If it's positive, you start prophylaxis immediately. Don't even wait for the confirmatory results.
Okay, let's shift gears to thromboembolic risk. We know pregnancy is a hypercoagulable state.
It is. About a 5 times increased risk for DVT or PE compared to a non-pregnant woman.
And when is that risk at its absolute highest?
It actually peaks in the postpartum period. This is why VTE, venous thromboembolism, is still a leading cause of maternal mortality in the developed world.
The real challenge, though, is managing patients who are already at high risk, say someone with a mechanical heart valve.
This is one of the toughest decision matrices in all of OB-GYN. It really puts the mother and fetus in direct conflict.
So warfarin is the most effective for the mother, right?
It is. It has the lowest rate of thromboembolic events, which is critical for her.
Yeah.
But it's a known teratogen.
Meaning it causes fetal malformations.
Yes, a risk of around 10%, especially in that first trimester.
So if it's dangerous for the fetus, what's the alternative?
The alternative is a heparin product, usually low molecular weight heparin, LMWH, because it doesn't cross the placenta. It's safe for the fetus.
But it's not as effective for the mother.
For a patient with a mechanical heart valve, no. It's simply less efficacious than warfarin. So you're truly weighing maternal survival against a 10% risk of fetal malformation. Yeah. It's a very difficult conversation.
That really underscores the complexity here. Okay, let's move into our final segment, dermatologic and pelvic health. Rashes in pregnancy are so common, but we need to differentiate them.
We do.
Let's start with the big two. PUPPP versus gestational pemphigoid. What's the key difference?
It's all about location. Location, location, location.
Tell me about PUPPP first.
So PUPPP, paritic urticarial papules and plaques of pregnancy, usually 3rd trimester. Itchy, hive-like plaques that start in the stretch marks on the abdomen. But the crucial detail.
Yeah, spares the belly button.
It spares the umbilicus completely.
Okay, so then gestational pemphigoid must be the opposite.
Exactly. It has a high affinity for the periumbilical skin. If you see lesions right around the belly button, that should be your #1 clue. It's an autoimmune blistering condition.
I've heard it used to be called herpes gestationis. Is there any link to the herpes virus?
None whatsoever. It's a complete misnomer. It was named that way back in the 19th century just because the blisters looked herpes-like.
And it's important to get that right because this one carries fetal risks.
It does. An increased risk of prematurity in IUGR, especially if it presents early in the 2nd trimester.
And what's the first-line treatment for the itching with these rashes?
We usually start with a combination approach. A non-sedating antihistamine like cetirizine for the daytime, a sedating one like diphenhydramine at night to help with sleep, plus topical glucocorticoids.
Okay, shifting to GYN pain. Let's talk fibroids. Which type is the worst for bleeding?
The location is key. The type most prone to causing abnormal uterine bleeding is the submucosal fibroid.
Because it's right there in the cavity.
Exactly. It impinges directly on the endometrium.
Hmm.
And remember, fibroids are hormonally stimulated, so they grow during the reproductive years and shrink after menopause.
And what about chronic pelvic pain? When should endometriosis be at the top of our list?
You should really suspect endometriosis when you have chronic cyclic pain that consistently peaks before the menstrual bleeding actually starts.
That premenstrual peak is the classic sign.
It's a huge clue. Now, definitive diagnosis is surgical, via laparoscopy, but we often manage the pain medically with hormonal options like DMPA to suppress ovulation.
Let's close with a serious post-op complication. Fistulas. What's the classic presenting symptom?
The classic sign is continuous urinary leakage right from the vagina after surgery,
And the two most common are vesicovaginal
an injury to the bladder,
and ureterovaginal.
an injury to the ureter.
So how do you figure out which one it is?
We use the double-dye tampon test. Put a tampon in the vagina, give the patient oral phenazoparidine, which turns her urine orange, and then you instill blue dye into her bladder.
Okay, so if the tampon turns blue,
The leak is from the bladder, a vesicovaginal fistula.
and if it's just orange?
If it's only orange, especially at the top of the tampon, that means the blue dye never got there. The leak is coming from higher up, from the ureter. It's a ureterovaginal fistula.
And what's the management principle? Do you rush to repair it?
No, absolutely not. The first priority is to preserve kidney function, which might mean placing a stent or a nephrostomy tube. Immediate repair is often doomed to fail because of all the inflammation.
So you wait.
You wait. We usually favor a delayed surgical repair, maybe 2 to 3 months later. It allows the tissue to heal and dramatically improves the success rate.
Wow. We have covered a huge amount of ground today. From, pica masking and iron deficiency to the incredibly high stakes of anticoagulation.
It's all about connecting those signs and symptoms to the underlying pathophysiology. That's the core of clinical wisdom.
Recognizing that high HCG mimics TSH, or that the location of a rash is the key differentiator.
Precisely. Those are the connections that drive good medical decisions.
So for all the learners diving into these cases, let's leave you with one final thought, a quick exercise.
Let's do it. Consider this. You encounter a patient in her 3rd trimester. She has a severe blistering rash, and it primarily affects the skin around her belly button.
Okay.
Based on the morphology and the distribution of her lesions, which dermatologic condition should you prioritize in your differential diagnosis, and why is its original historical name so misleading?
A perfect question to mull over. Use what you've learned to guide your thinking. That's all for this deep dive.